Greetings and welcome to our segment of the Satellite Symposium on ILD solutions. Today, we will be discussing solutions to the treatment of systemic sclerosis-associated ILD. I am Maria Padilla, and I am a professor of medicine and the director of the ILD and IPF program at the Icahn School of Medicine in New York City. Dr. Margrit Wiesendanger is joining me today, and it's my great fortune to have her as a colleague in this discussion. She is an associate professor of medicine at the Mount Sinai School of Medicine in the Division of Rheumatology, and she is quite an asset to any pulmonologist. Every pulmonologist should have a Dr. Wiesendanger with them to collaborate in the care of their patients who have such complicated illnesses as we are about to discuss today. This presentation has been created with the help of the France Foundation, an agency that is well recognized and accredited for its initiatives in continuing medical education. This activity provides you with both CME and mock credit, and you can get the full information on that URL that you see posted in the right upper corner of your chart. Our disclosures are located here for all of you to be aware, and you can claim your credit after completing this evaluation. At this point, I would also like to thank Boehringer Ingelheim Pharmaceutical Company for providing an educational grant that supports this activity. Our gratitude is for them also. Thank you. So ours is just one of the segments, but you see here that there are other symposia that are going on, and the next one is happening on Tuesday and thereafter on Wednesday. You will be specially recognized if you attend 4 of these symposia, and also depending on your engagement and participation in our session today, you may be eligible to win a prize, as we will have questions and polling, pre-test questions and polling questions for you to answer and participate actively in this. Please make sure to check your bar on the right-hand side, where you will find the answers to the polling questions, or at least the results of the polls. So the objectives of this session today include reviewing the therapeutic options for the management of systemic sclerosis-associated ILD. We want to develop a management plan to monitor our patients throughout the course of treatment, and also to monitor the progression of their disease. We would like to have information on management of extrapulmonary conditions as they affect our patients and alter their survival and prognosis. So let's go into our first pretest question, and it relates to a patient who is diagnosed with systemic sclerosis and has respiratory system. Which of the following is the most important risk factor for developing ILD? A, the percent of neutrophil in the bronchoalveolar lavage fluid, the severity of their Raynaud's disease, their autoantibody status, or their serum TGF-beta levels. For our next question, We have a 60-year-old patient who has systemic sclerosis and now presents with progressive shortness of breath and has evidence of interstitial lung disease on a chest radiograph. You now order a high-resolution CT scan, and I'm glad it's a high-resolution CT scan of the chest, and you will expect to find the following: A, NSIP or UIP pattern; B, interstitial reticulation with pleural involvement; C, apical fibrosis; D, significant air trapping on expiratory images; or E, diffuse cyst. Again, please keep an eye on the chat on your right-hand side. And now for the pretest question number 3, we are dealing with the comprehensive management of systemic sclerosis, which is a continuous and multidisciplinary approach. Baseline and periodic evaluations are necessary and include all of these listed except pulmonary function test with all its parameters, skin score assessment, as well as other organ involvement, bronchoalveolar lavage, high-resolution computed tomography, echocardiogram, and cardiac catheterization, if indicated.
So I would like to add my thanks to the organizers and also Dr. Padilla, my wonderful colleague, for that generous introduction. I'm really glad to be here as well. So, and indeed, it is an interdisciplinary, multidisciplinary approach that is needed for systemic sclerosis. It's a challenging disease for many reasons. Among these is that it's a very heterogeneous disease in terms of the distribution of skin involvement and also the internal organs that may be affected. At the same time, it's very rare. The prevalence is only 150 to 400 per million, depending on estimates, with an incidence of fewer than 10 to 20 per million per year. And despite this, the burden of morbidity and mortality is very high, with high standardized mortality rates and low survival at 10 years. So why are we talking about interstitial lung disease? This is the leading cause of death now in systemic sclerosis, surpassing renal crisis. And patients have a varied progression. Some patients have a slow indolent course. Others have rapidly worsening symptoms. It's important to accurately decide how to stage and manage these patients. In addition, they may have other comorbidities coexisting with the lung disease that could have an adverse impact on their outcome. And so while an optimized therapeutic strategy has yet to be established, several modalities have been proven helpful. We'll discuss some of these today. So this is just an overview of the organ complications that can be seen with systemic sclerosis. And here you have, if you look at across the board, all of the patients with scleroderma, about 40% will have some form of interstitial lung disease. Most of them, the vast majority, 90%, will have gastrointestinal complications, which can affect any part of the tract from the mouth to the rectum. A majority, 2/3, will have musculoskeletal problems, which could be myopathy or arthritis. And many will also have the skin fibrosis, which we'll discuss. More than 90% will have some form of skin involvement and Raynaud phenomenon, which often precedes the onset of other features by 10 years, up to 10 years. In the skin, you also have telangiectasias in 3/4 of the patients. The Raynaud phenomenon can become complicated with ulcers, and calcinosis can also occur on the extremities or the trunk. Any part of the skin can be affected. Thankfully, rare is renal crisis, now down to 5 to 10% because of effective treatments, and about 15% of patients will have pulmonary arterial hypertension, which can complicate the lung disease. So if Dr. Padilla, take us through some of these lung manifestations, if you would.
Well, first, here we see a radiograph that depicts increasing markings throughout the lung, but predominantly at the basis of the lung, as we see here. And in the bottom image, we have a CT scan that is characterized by these reticular lines, as well as by ground glass density that we see here, with perhaps a slight sparing of the periphery of the lung. This is consistent with an NSIP pattern that can go on to fibrose. And when it does, then we can look at their pathology and see that the pattern that we have here of fibrosing lung disease has altered the morphology and the architecture of the lung, and almost looks like a UIP pattern at this point, but it's characterized by diffusely thickened septa, as we see here. And one distinguishing feature that is important to remember is that we have vasculopathy, not only fibrosis, but we have here a vessel depicted where we can see that there is intimal proliferation of this vessel. And that is a characteristic or a feature that we see in patients with scleroderma lung disease.
So to illustrate some of these points, we'd like to present you a total of three cases taken from our clinics, and this will illustrate some of these things. So in our first case, we have a 6-year-old woman with Sika syndrome and fatigue. So back in 2013, she developed Raynaud phenomenon. It was biphasic with pallor and cyanosis and triggered by cold. A year later, had Sika symptoms and a positive SSA serology, Sjogren's syndrome A, and rheumatoid factor, which led her physicians then to diagnose her with Sjogren's syndrome. But that same year, she consulted a pulmonologist, and CT imaging showed evidence of interstitial lung disease. They excluded alternative diagnoses, including hypersensitivity pneumonitis. She was, though, asymptomatic. She had no cough or dyspnea at that time. And then 2 years later, her resting oximetry was still normal, but on pulmonary exam, there were bibasilar crackles and no digital clubbing at the time. Despite this relative lack of symptoms, she was showing progressive bibasilar interstitial fibrosis with honeycombing on her CT imaging compared to 2014. That same year, the presence of RNA polymerase III antibodies was noted, and so she was recommended to start mycophenolate mofetil. However, despite becoming more symptomatic with persistent cough, she declined immunomodulatory therapy at that time. So the first question, this is just for thought, does this patient at this point, given what I've just said, does she meet classification criteria for scleroderma? Yes or no? So let you think about that for a second. And the thing is, no, based on what I've just said. And this is why. So I'm showing you here the 2013 American College of Rheumatology and European League Against Rheumatism criteria for the classification of systemic sclerosis, with always the caveat that these criteria were not really designed to be diagnostic criteria, but rather to classify patients and accurately enroll them in clinical trials. However, they are still very helpful for us as clinicians because they highlight the most important features that distinguish scleroderma from other diseases that may resemble it. And in this case, as in others, the criteria are being revamped by the ACR and the EULAR together to change from sort of major features, minor features, take 2 of these, take 3 of this. Rather, points are being assigned to classic features. And if you add up all the points and you have more than a certain number, in this case it's 9, then you could be reasonably confident that you're dealing with scleroderma. So in this case, if you have skin thickening of the fingers of both hands, which reaches not just the extremities, but moves proximal to the metacarpophalangeal joints, that's 9 points right there. This is a diagnosis of scleroderma. You don't need anything more. But this patient lacked that specific feature. She didn't have any skin thickening or barely any at the tips. So then you move to the other items, and you have the items with sub-items, and you only count the sub-item. If 2 sub-items are present or more, then you only count the highest scoring one. So for skin thickening, you can count puffy fingers, so this is a diffuse soft tissue swelling, or sclerodactyly, you get more points for sclerodactyly. You can look at fingertip lesions, which could take the form of digital tip ulcers or fingertip pitting scars. She lacked that. You can look for telangiectasias, abnormal nail fold capillaries, 2 points for that. Pulmonary arterial disease or interstitial lung disease, each is worth 2 points, but you only count 1. for the classification criteria. Raynaud phenomenon alone is 3 points. And scleroderma-related autoantibodies, you have these three major ones: centromere, topoisomerase LCL70, and anti-RNA polymerase 3. These are the ones that are included in the criteria. Typically, patients will have just one of these three, unlike the case in lupus, where more than one autoantibody may be present. So what this patient had was the Raynaud phenomenon, she had the RNA polymerase 3 antibody, and she had the interstitial lung disease. That's 8 points. So why are autoantibodies so important? They do help us prognosticate for the patient. So here I'm showing you a table taken from Nityanova et al. In Arthritis and Rheumatology, where they propose a classification of scleroderma using autoantibodies and skin subset as criteria. So combining the two to try to come up with a better way to prognosticate. So we're showing the percentage of each of these manifestations in each group at 15 years post-diagnosis. So the cumulative incidence of these complications at 15 years. So I want to highlight some of these. If you have topoisomerase or SCL70, it's the same antibody, regardless of the extent of skin involvement, be it limited or diffuse, you are having a high risk of pulmonary fibrosis. 86, 84% of this group have it. So this is interesting because it suggests that the antibody is driving the pulmonary fibrosis risk more than the extent of skin involvement. Nonetheless, skin involvement is very important because patients with diffuse skin involvement have the lowest survival if they have the topo antibody or if they have the other antibodies. In this case, it includes UNRNP, THTO, and SSA-SSB. So in contrast, you have centromere, this is ACA centromere positive patients who tend to have limited cutaneous disease and, apologize for that, let me go back, limited cutaneous disease and a risk of pulmonary hypertension around 14%, but only 9% of them have pulmonary fibrosis. RNA polymerase 3 is shown in the fourth column here. And it's important to note that these are not absolute, it's not 100% of the risk which is attributed to the antibody, but those patients have a 45% of them have pulmonary fibrosis at 15 years, and 28% of them have the renal crisis. But their survival is a bit better than their colleagues in the topo positive group. So that's where autoantibodies and skin involvement are helpful. So here is a question. So Dr. Padilla, if you would please take us through the...
So in this particular patient, all of the followings are reasonable options, except refer to rheumatology, B, initiate high-dose corticosteroids, continue to monitor clinically, or refer to the ILD center or for a multidisciplinary discussion to help with the decisions as to management of this patient at this point. Please.
So we're going to reveal the answer. Yes.
Okay. This is contraindicated in patients with systemic sclerosis, particularly those who have the RNP polymerase 3 that is positive because of the fear that it may precipitate renal failure in these patients.
Here's, keep going with this case, please, Dr.
Yes.
Padilla.
So at this point, patient is referred to our institution for a third opinion regarding the presumed diagnosis of Sjogren's syndrome. And here we see that this patient now has progressive exertional dyspnea with uphill. She has other findings that suggest that this diagnosis is well established, such as aperistalsis of the esophagus. At this point, since we did not have all the findings that we needed to establish a diagnosis, and this is not an uncommon presentation to all of our pulmonary colleagues or to ILD centers. So what we did is we referred to rheumatology in order for them to help us establish this diagnosis and then proceed with the appropriate therapy. So she is at this time diagnosed with scleroderma based on all the findings, and in addition, the presence of these dilated nail fold capillaries that we can see and appreciate here with capillaroscopy being performed. So this essentially will then clinch her diagnosis of scleroderma. And upon discussion in our multidisciplinary conference, this diagnosis is well established, and so now we can proceed with treatment of patient. We also like to look at her breathing test or other parameters that will help us guide the decision to treat with her. Because remember, she is reluctant to undergo therapy. Next. We did her high resolution CT scan, and what we find here is that initially in 2014, she has findings of reticulations in a peripheral distribution. This is a pattern that if she were asymptomatic can be considered ILAs, but it's already approaching the probable diagnosis of UIP. By 2016, it becomes more evident, and that we see that she is already having honeycombing or bronchiectasis of the distal airways here. And this is 2 years of progressive lung disease, so that we know that she is of the progressive phenotype at this point, despite her maintaining a relatively good functional status. And this just continues by 2018 to have what are some features that we may associate with connective tissue disorder. We see honeycombing here, and this honeycombing is involving the whole lobe, as we see here. So these features of this florid honeycombing that we see can be seen in connective tissue disease, and it can also be seen on UIP-IPF, and it's sometimes difficult to separate these two entities, but we see on the next thing, the classic signs that should raise our index of suspicion for a patient having connective tissue disease when we are looking at an UIP pattern. These 3 signs are very sensitive for diagnosing underlying connective tissue disease, and in a patient with scleroderma that this represents, we see here the anterior upper lobe sign appreciated in the upper lobes and in the anterior aspect of this. We see it better on the sagittal view here, where we see the findings close to the chest wall anteriorly. The other sign that we see in patients with connective tissue disease is that of a straight edge sign. And we see it here demarcating normal lung from the involved lung at the basis of the lung, and it's on both sides. So this straight edge sign is very helpful. It points out here that when you look at your CT scan, please look at them in different views so that you will be able to pick up these findings. Also look for any other findings that may help you. And here we see that this is a dilated esophagus, which will then help you make this diagnosis. And then finally, we see here what we call exuberant honeycombing. Here is complete involvement of the lower lobes by these cystic areas that have very thin walls, and this is very profuse and therefore called exuberant honeycombing. If you see 1, 2, or 3 of these signs, think please of connective tissue disease in a patient with ILD, and work them up completely to make this, to establish a definitive diagnosis. We looked at her PFTs, and we see here that despite her progression on CT scan, this patient maintained relatively little loss of function, throughout this period of time that we had. Further, supporting her decision not to be treated at this time. Next. Okay. So what do we do to evaluate a patient with interstitial lung disease associated with scleroderma? Essentially what we do with a lot of our patients with interstitial lung disease. Certainly the complete PFTs are there. We need a form of gas exchange assessment. That's our 6-minute walk. Our serologies are very important and they should be comprehensive. Our CT scan should be high resolution CT scan of the chest in order to better establish the pattern of ILD that we have. Patients with connective tissue disease have an electrocardiogram, have an echocardiogram. We work in tandem, we work in collaboration with our rheumatologists, and we always utilize our multidisciplinary discussions to try to help us establish a more accurate diagnosis. In some patients, we may need to go to cardiac catheterization to assess the degree of pulmonary hypertension and to exclude other causes of their arterial hypertension. A cardiac MRI may become important in these patients, and in rare patients where we can't explain their restriction, we may have to look at their muscle strength and see if they have developed a stiffness of their chest wall that prevents them from expanding their lungs. These studies we do at baseline. Next slide, please. And we do it at repeated intervals throughout the course of their illness. In the early disease, in the first few years from the diagnosis of that, they are repeated with increasing frequency. So every 3 to 6 months, we will do full PFTs in these patients. We may slow down the frequency when the disease is established and we have learned a little bit about their behavior and course of illness. Echocardiogram is important to do at least yearly. Cardiac cath only when indicated. A high resolution CT scan should be obtained at baseline, should be obtained every 12 months, at least at the beginning of their disease. And we look at this CT scan. Here it says every 6 to 12 months. We tend to do it mostly for 12 months. And we're looking not only at the progression of the disease, but we're looking for the possibility of associated findings, such as the emergence or the development of a carcinoma or other forms of neoplasm. If the patient decompensates and has change in symptoms, we may need to do this with contrast to exclude the possibility that they're having thrombotic events or embolic events. So their GI study should be done at baseline and then repeated as we need to. So this is the monitoring of the disease along the course of illness. Laboratory works are done routinely on these patients, and we do obtain a BMP because it can help us make us suspect the possibility of pulmonary hypertension. So at this point, given the above clinical information that we have had on this patient, what is the best modality to determine progression of her lung disease? A, CT scan imaging of the chest, spirometry with DLCO, 6-minute walk test, D, her functional class, or E, all of the above. All of the above. Okay, not one single test can tell you what the progression of the lung disease is in any given patient. We need this composite imaging and composite functional status. Next.
Excellent. All right, we have another case for you. So this is a 38-year-old woman with scleroderma and new onset exertional dyspnea. So she was diagnosed, she noted the onset of Raynaud phenomenon at age 17 years back in 2000, and had also gastroesophageal reflux disease. At that time, she was given hydroxychloroquine for associated arthritis for about 2 years. And then 10 years later, she was noted to have interstitial lung disease associated with scleroderma. She was ANA positive as well as SEL70 topo positive. She was given treatment for the Raynaud phenomenon and fingertip ulcers with tadalafil, but low-dose corticosteroids had a minimal impact on her lung disease, so were discontinued, and her lung disease remained stable at that time. She was able to continue working full-time as a registered nurse. But then in November of 2018, she suffered an acute decompensation with exertional dyspnea, an very abnormal CT scan. She was admitted to the intensive care unit because of respiratory failure and cor pulmonale. And eventually, when she was discharged home, she required supplemental oxygen. A year later, she was referred for a second opinion and had several concerns, including pulmonary lesions, cardiomyopathy, pulmonary hypertension, and transaminitis, and with symptoms of daily cough and exertional dyspnea limited to just going up 15 steps on stairs. Her clinical exam at the time disclosed minimal bibasilar crackles. There was no digital clubbing, but she did have skin tightening consistent with scleroderma. So these are her CT scan images.
Okay.
Dr. Padilla.
This was on December of 2018 when she's admitted in respiratory failure. And what we see here is that there is a development of a nodular density with a central lucency. This will be very concerning for the development of a neoplastic disease. However, she is treated with several medications, and we will see later that this is improved. But what we also see is that she has developed or presents with the findings of exuberant honeycombing already and significant traction bronchiectasis and fibrosis of the lung. Just 3 months later, these findings have disappeared, but not so the fibrotic changes that she has. So this particular patient has very advanced lung disease. Her pulmonary artery, if you could appreciate it better here, is enlarged and indicative of pulmonary hypertension. So this is a young woman who had several risk factors for development of ILD and scleroderma and for the comorbidities that come with this. She had diffuse cutaneous systemic sclerosis, as we see. She was of African American ethnicity. She had the presence of Sclerosis antibody and absence of anticentromere. She happens not to have all of these risk factors, but these risk factors have been well documented to increase the risk of developing ILD and scleroderma, and to do so in the early years from presentation of their scleroderma. Her pulmonary function studies are revealing, and that we see that already in 2011, she has moderate impairment in forced vital capacity and severe impairment in heart diffusing capacity. We note here that in 2015, with relatively well unchanged forced vital capacity, she has a significant drop in her diffusing capacity. And this is very important for us to note or to look at when we see our patients, because this ratio of forced vital capacity to DLC, to diffusing capacity, that is greater than 1.6 or 1.8 is a clue to the presence of pulmonary hypertension. And perhaps had we intervened at this time in 2015, we could have already treated this patient for what she presented with in 2018 when she had her decompensation. So with this particular patient, We did do her echocardiogram that indeed revealed the presence of pulmonary hypertension by an estimated pressure of 62 millimeters. The echo is a very good screening test for pulmonary hypertension, but remember that it can over or underestimate the true value of that. And it doesn't tell you whether this is left-sided pulmonary hypertension or right-sided. You do need to have a cardiac catheterization in order to establish pulmonary hypertension. And at the time, this patient had severe pulmonary hypertension with a mean pulmonary artery pressure of 43 millimeters of mercury. So what did we do for her? We instituted mycophenolate mofetil in the March of 2019, maintained her on her medications that she had been on, and the furosemide for her right ventricular dysfunction also, and initiated therapy for pulmonary hypertension with additional agents. So she had macitentan and followed that by selexipag. And this is under the guidance of our colleagues in pulmonary hypertension. What is gratifying to see is that compared to 2019, by now, she has had an improvement in her forced vital capacity. And she is increasingly more functional, and we were able to stave off her lung transplantation to which she was already referred. Her diffusion capacity has not changed significantly, so she continues on current therapy at this point. So how do we stage the severity of a pulmonary disease? I think we have alluded to this in the past, and no single test has been validated to correlate with severity of disease, and composite scores that are made up that include function, PFTs, and imaging may be the best way of staging the severity of the disease. The baseline risk factors and antibody type we have heard have also correlated with the severity of disease, or at least hint at what may progress in patients who have a particular one. So the CT scan and PFTs, which are two elements, two parameters that we easily obtain on our patient, have been used to guide the severity of illness in our patient, and also to correlate with mortality, survival of these patients. And if you characterize a patient as having extensive disease, meaning greater than 20% CT scan involvement in a forced vital capacity that is less than 70, which our patient would fully be within this range, they have extensive disease. If it's less than 20% on CT scan and FVC is greater than 70, they have limited, minimal, or mild disease. Any emergence of pulmonary hypertension or lung cancer, by definition, will imply that the patient has severe pulmonary disease of their ILD. And so it's important that we follow them not only at baseline, but throughout their course of the illness, and particularly in the short term at the beginning. So this staging of severity of disease has come to us from Go and her colleagues, and has withstood the test of time. So it's a robust measurement. So if the patient has limited disease, their survival is significantly better than if they have extensive disease, meaning greater than 20%, and FVC less than 70% to predict it.
All right, here's our third case. So Here's a 48-year-old woman with seropositive rheumatoid arthritis and progressive shortness of breath. And you can see this pattern where patients with autoimmune conditions may be diagnosed differently when they first present for medical care. And that's because there are some features that could be confusing or shared between these different systemic autoimmune syndromes. And yet, the onus is upon us to really be as accurate and precise as we can. So back in 2010, she was diagnosed with rheumatoid arthritis justifiably based on a high positive cyclic citrullinated peptide antibody and hand arthritis. She also had Raynaud phenomenon, which would be less typical for standard cases of RA, shall we say, or typical cases of rheumatoid arthritis. And then in February 2019, she then developed puffy fingers and a high positive SEL70 topo1 serology and pulmonary function testing that showed restrictive lung disease. So now I wrote here, diagnosis change to systemic sclerosis. I guess you could call her an overlap because she meets criteria for both. However, systemic sclerosis is the one that's more important now for her prognosis. So in April of that year, she was started on mycophenolate mofetil and low-dose prednisone, and CT scanning of the chest a year later showed similar findings to the prior. But in July of 2021, she sought a second opinion for her arthritis, which had not improved the mycophenolate and corticosteroids. So this is a photograph of her hands at the time of the visit. And what you're seeing here is diffuse puffiness of the soft tissue over the whole hand, as opposed to, say, the synovial hypertrophy that would be more over the wrist, MCPs and PIPs in rheumatoid arthritis. And she's unable to make a full fist because of all the soft tissue swelling. Additionally, she had nail fold capillary changes here with dilated nail fold blood vessels and symmetric myopathy. So at this point, it was important to get a better sense of what was going on with her lung disease. And so the pulmonary opinion at the time was, let's at least increase the mycophenolate to a treatment dose, give her the highest allowable dose of prednisone for a patient with scleroderma, which is 10 milligrams daily. And these are her CT scan images.
Here, in this particular case, we see that in August of 2020, we are dealing with ground glass changes with reticulations and maybe peripheral sparing, mostly right greater than left at this point. There is some evidence of traction bronchiectasis on the left side that we can see, but we see by August of 2021 that this has progressed. And again, this is a patient who in the course of 1 year is progressing on CT scan, marking her as someone who needs to have additional therapy at this point to control her underlying interstitial lung disease. And this is probably the best time to intervene with our patients at this point. And so we need to discuss and collaborate with our rheumatologist as to what to do for her next. So her PFT supported the change in CT scan that we see, where she drops her forced vital capacity in just from March of 2020 to July of 21 from 2.30 liters to 1.87. So she's had a significant drop in forced vital capacity, another marker of progressive lung disease and ILD. A drop in forced vital capacity within a year of 10% or greater will mark a patient as progressing in her disease, as will the drop in DLCO of 15% or greater in that period of time.
So when we are approaching scleroderma, we have several imperatives. The first is to be able to determine the disease phenotype and disease stage as accurately as we can, given the heterogeneity of the disease, and we're really practicing precision medicine when it comes to this. And there are really two arms to the strategy, which they're not mutually exclusive, but on the one side, we are engaging immunosuppressive therapies to try to bend the arc of the disease and stop the immune response that is triggering all the damage, the endothelial dysfunction and the fibrosis. And on the other hand, we have to handle the endothelial dysfunction and the fibrosis using either vasodilators or anti-fibrotics or combination. We must be mindful of the threat of malignancy in patients with systemic sclerosis because they have an increased risk of many types of cancer, including affecting the lung, the bladder, hematologic system, liver, non-melanoma skin cancers, oropharynx and esophageal cancers are also seen in patients with scleroderma compared to the general population. The risk factors include, as we have mentioned also for ILD, an older age of onset, diffuse cutaneous involvement, the presence of interstitial lung disease, and the RNA polymerase III serology. So the current recommendations emphasize the following. Patients should undergo a comprehensive physical examination, including the lymphatic system, the skin, oral cavity, thyroid. Women should receive cervical cancer screening and mammography as appropriate. All patients should have colonoscopy screening as age appropriate. And in selected high-risk patients, not just computed tomography imaging of the chest, but also the abdomen and pelvis, endoscopy, upper and lower endoscopy, serum and urine protein electrophoresis, peripheral blood flow cytometry, and even serum tumor markers, which we typically don't get on patients. So immunosuppression, old and new. So there are some therapies that have been used in the past that are being supplanted by some newer modalities. So I just want to mention that deep penicillamine and especially high-dose corticosteroids are no longer being used for the treatment of these patients. We shy away from the use of methotrexate because methotrexate pneumonitis could emerge and complicate the picture in a patient who has established or the beginning of interstitial lung disease. Cyclophosphamide may provide a statistically significant improvement in the forced vital capacity, but the clinical benefit of the drug overall does not seem as appealing given the side effects. So we're now looking at newer drugs like Nintetanib, Tosolizumab, rituximab is being studied. Some of these things are in trials or are not yet published. Intravenous immunoglobulin, vasodilator therapy for ILD, and autologous stem cell transplant. We'll highlight some of these for you in a moment. So clinical trials, what have we learned? There are many trials have been pursued, even though this disease is very rare, and not all have been successful. So we want to show you some of these things. So here is the SCOT trial. So this is a myeloablative autologous stem cell transplantation for severe scleroderma. I'm showing you the key figure here where on the left you have the group with the transplant who received the transplantation in red versus the patients who were treated with cyclophosphamide in blue. And you can see that overall survival is better in the transplantation group compared to cyclophosphamide. The curves separate at 2 years. And if you look at event-free survival, the same trend is seen. After 2 years, the transplantation group does better than the cyclophosphamide group. Should bear in mind that this type of transplantation for non-malignant indications can only be done in certain specialized centers, and the mortality rate, although improved compared to the initial studies, is still about 10%. We have also Tosolizumab, the anti-interleukin-6 receptor, which was studied in patients with systemic sclerosis with or without interstitial lung disease at baseline. And here I'm showing you the mean change from baseline for FVC percent predicted at week 48. In red, you have the Tosolizumab group, and you can see that they're maintaining their FVC over the course of the study. Whereas in blue, the placebo patients, so these are patients who have relatively early scleroderma and are not treated with any background therapy. So patients on placebo lose up to 5% of their FVC predicted over the course of the study. If you then just look at the patients with interstitial lung disease at baseline, the same is true, although there's even a little bit better improvement. And I just want to emphasize the maintenance of FVC is actually a win in scleroderma. Nobody was expecting the patients to necessarily recover FVC, although we're delighted when it happens. This is actually a very encouraging study. And Dr. Padilla, if you could tell us about pulmonary hypertension studies, please.
We have had some encouraging studies, and we'll discuss the anti-fibrotic subsequently. And so the Tosi story is also a positive one here. And as you have seen, in contradistinction to the pulmonary arterial hypertension clinical trials, these have been a multitude of clinical trials. We started first with Pharos, who is a registry that was involved in the pulmonary hypertension assessment and recognition of outcomes in scleroderma. Here is where we identify risk factors that are associated with the development of either pulmonary hypertension or pulmonary arterial hypertension. Here we learned that diffusing capacity of carbon monoxide was less than 55 was associated with pulmonary arterial hypertension. We also learned that the FVC over DLCO ratio greater than 1.6 is a marker for this, as well as that their pulmonary artery pressure greater than 40 are risk factors for the development of this, and we should keep that in mind. Next, the REVEAL registry evaluated early and long-term pulmonary arterial hypertension disease and is the largest registry of pulmonary arterial hypertension with patients in the United States. Here, a large number of these patients included scleroderma patients, and we learned that scleroderma-associated pulmonary arterial hypertension is the second most frequent cause of pulmonary arterial hypertension in both the United States and also in Europe. And that the presence of this pulmonary arterial hypertension has increased the mortality of our patients, particularly if they have underlying lung disease. The next slide depicts a number of clinical trials that I will not go into any great detail, but what I wanted to bring to your attention is that contrary to this trials in interstitial lung disease, we have learned a tremendous amount from the trials that have been conducted in pulmonary arterial hypertension. And all mechanisms of developing pulmonary arterial hypertension seem to be targeted by one or another one of these drugs. And what the other important thing is that combination therapy is the rule practically on all our patients who have severe pulmonary arterial hypertension. And that's why we saw in our patient that we layered one vasodilator or antipulmonary hypertension agent on top of another. And this is based on clinical trials that have proven the efficacy of these various agents in the management of pulmonary arterial hypertension. So we have seen that the phosphodiesterase inhibitors have worked. We have seen that the endothelin antagonists have worked. We have seen that oral prostacyclin things have worked. And the combination has been successful. We have also seen recently that inhaled vasodilators have worked in the pulmonary hypertension of interstitial lung disease. So this is very promising, and we wish that we had similar list of clinical trials in interstitial lung disease, because the survival of the patient with pulmonary arterial hypertension, idiopathic, has changed due to these various trials and discovery of efficacious medication. But for us, we have anti-fibrotic therapy for scleroderma, and we want to review the census trial, which led to the approval of the first agent for treatment of scleroderma-related interstitial lung disease. And the census trial is the use of Nintetanib, tyrosine kinase, inhibitor in systemic sclerosis associated interstitial lung disease. And similar to the history, the TOSI trial that we saw before, we saw that the decline in forced vital capacity of the patients on Nintetanib were less than that of the placebo. This was significant enough to lead to the approval of this agent as the first agent to treat interstitial lung disease or pulmonary fibrosis and systemic sclerosis. And we see here that this included a robust group of patients. There were 576 patients that were either randomized to receive Nintetanib or to receive a placebo. Some of the patients had background therapy and had mycophenolate. And what was interesting to see is that those patients who had mycophenolate demonstrated less of also a positive effect. They had lesser of a drop in their pulmonary, in their forced vital capacity compared to those patients who were not on mycophenolate. So Nintetanib, both with and without mycophenolate, led to positive results in these patients. Whether we add them simultaneously or we add them sequentially, we still don't know when it's the right time. But at least having this as a potential door to further studies is great. And so having two now approved agents, Tosi and Nintetanib, is a great thing for our patients with Scleroderma ILD. With that, let's summarize some of the important concepts that we have. As we have heard, it is a heterogeneous disease in which both the endothelium and the immune activation are playing a role in triggering and perpetuating the fibrosis. We have learned about the classification, and I think that as a pulmonologist, I will rely more heavily on this classification, as I have learned from my colleague, Dr. Wiesendanger. We know that interstitial lung disease and pulmonary hypertension increase morbidity and mortality of our patients. And as we heard from Dr. Wiesendanger also, is that we need to tailor our therapy according to the disease stage and manifestation so that we can target both the autoimmune response as well as the vascular anomalies and the fibrotic changes. So these novel therapies have now been showing promising results, and we need to continue to do this by ongoing clinical trials and by having interstitial lung disease programs that are interested in furthering or advancing the science of ILD associated with scleroderma or other ILDs. Next. So here at the Icahn School of Medicine, we have Ild Registries that help us with that. We also participate in all clinical trials, and we have associated clinical programs with whom we work very closely to try to provide the most comprehensive care of our patients with ILD, connective tissue ILD, and other forms of interstitial lung disease. With this, we thank you very much for your attention and hope to answer any questions that you may have at this time. Mm-hmm.
So there are a couple of questions in the
Yes.
Q&A here. So the first is, when should we decide to send someone for hematopoietic stem cell transplant, a very risky procedure. And the questioner is saying we either find these patients to be too well or too sick to undergo this. And I think that is a challenge. We at Mount Sinai do not perform this procedure, so we would have to refer to another center. I've yet to send a patient for this procedure. I don't know, Dr. Padilla, do you have any experience with stem cell?
No. And I think that part of the problem is the high morbidity that comes with the patient. The results are positive in the long term, but we do have a front end that has high morbidity and mortality.
Right. We have another question, which is, what is the proportion of patients that will qualify for Tosolizumab, considering that in the study that I presented, they had to have a high CRP in order to be eligible. So they had to have a CRP greater than 6, and ESR greater than 28, or a platelet count greater than 330. I mean, I guess I would still consider it for my patients, even if they had a normal CRP. I think we would have to look at the whole context, how they responded to CellCept, to mycophenolate, I'm sorry, what the progression of the disease was. I would not disqualify them necessarily based on a normal C-reactive protein.
And remember that this study also included patients who were early in their disease at a time when the autoimmunity and the inflammatory components of the disease are more prevalent. And so when do you decide to give TOSI as opposed to giving mycophenolate or less likely rituximab or cyclophosphamide? It's going to be a question that we'll probably answer in the next few months. This has just recently been approved for this, and it may be that the patient who has not been able to tolerate any of the other agents becomes a very good candidate for the use of the TOSI at this point.
Right. So, Dr. Padilla, would you like to comment on the preference for using Tosolizumab versus Nintetanib for a patient with progressive interstitial lung disease?
Oh, very good question. I think that we know for sure that the effect on fibrosis is positive from Nintetanib. We have not looked at TOSI in very well-established fibrotic disease. And as a matter of fact, there was a study carried out that showed that in failed mycophenolate and other immunosuppressive agent, adding TOSI did not result in a beneficial effect. So in that particular setting where we have failed other agents, I would prefer to go with an anti-fibrotic medication at this time.
Okay. There's a question about the dose of mycophenolate that we aim for. So typically in lupus nephritis, we would aim for the full dose, which would be 1.5 grams twice daily, so 3 grams daily. Generally in systemic sclerosis, we aim for 2 grams. I do like to check a trough level of mycophenolic acid to understand how the patient is absorbing and metabolizing the drug. So that is sort of what we do. And then regarding the progressively fibrosing phenotype, another question about Tosolizumab versus Cytoxan, Rituxan, Nintetanib. Do we only do this within clinical trials, or do we treat our patients in the clinic with these agents? Well, we do both, right? We do trials and we treat patients. So this is it's an individualized decision based on.
And we collaborate with our rheumatology colleagues because they have experience managing some of these immunosuppressants much better than we do, although we are catching up and learning pretty fast how to manage our patients.
This is the fun of medicine, is collaborating interdisciplinary approaches. So we believe that maybe the earlier phase patients with scleroderma would have more inflammation, and then if the disease is well established and there's a lot of honeycombing, let's say on the CT scan or the pulmonary function tests show quite a bit of reduction of the FVC, then maybe this is more the fibrotic phase of the disease, and we should be thinking more about anti-fibrotics.
Yes.
And looking for pulmonary hypertension. So when can we use Tosi? So early on, I guess, is the answer, right? Early,
Right.
if you can.
Yeah.
We're counting on our colleagues, our physician colleagues, nurse practitioners to send these patients to us as early as possible.
Yeah.
That's one of the reasons why the criteria were updated to try to help physicians recognize the disease in its earlier stages. The trough for mycophenolate, that may depend on the laboratory you're using, and they will give you a range of expected, and you could check sort of, it's one of those things, it's as needed. If the patient's not responding as you had hoped, if you want to know, make sure they're actually taking the medicine or absorbing it at all. That would be, otherwise it's not routinely done if it's really based on how the patient is doing and what question you're asking. So, and finally, if the patient had not responded to mycophenolate, would we then move to Tosolizumab?
Okay.
Again, if we thought it was early disease with a lot of inflammation and they didn't tolerate mycophenolate. So that's the other problem with mycophenolate, is the GI tolerance of the drug, not just the absorption and metabolism. So one could also go to mycophenolic acid. If a tolerance were an issue, that tends to be easier on the GI system. So one could try that. All great questions.
They're wonderful.
More in the chat.
Okay, so we thank you very much, and please don't miss the other meetings in this series, and be recognized for your attendance to all of these meetings, and hopefully you will win a prize from the Friends Foundation for your engagement on the polling questions that we had and everything else, and I've been looking at them, and they've been very, very informative to us also. So thank you very much for your participation, and thank you to the CHESS conference organizers and meeting, and to the Friends Foundation for putting on this very important series of symposia.
Thanks, everyone. It was a real pleasure.
Thank you.